Hello, my name's Rowlands and I'm a paediatric emergency consultant working at the Leicester Royal Infirmary. I'd like to speak to you today about some rarer causes of deterioration in children, but also to give you a system to help you, when you examine them, exclude systematically things that may be wrong. But to do that, I need to tell you a story first of all, about a little boy called Takanu. Takahu was a little boy who I met when I was working as a clinical fellow at the Princess Margaret Hospital in Perth, Western Australia, about 4 years ago. Takahu had arrived in the early hours of the morning following a single episode of vomiting blood at home. His parents had taken him to his local hospital and they'd arranged transfer to Perth. Interestingly, he'd actually been a patient 3 weeks previously because he'd swallowed a button battery and this had become stuck in his esophagus. This was removed 14 hours later by an endoscope and he was kept in hospital for a few days to check that he was okay. On this occasion, he'd been stable for the transfer and he'd needed no resuscitation. The doctors overnight had put in a cannula and done some bloods, which were all normal. The ITU staff had been down to examine him, and the plan was to send him up to the unit to be observed for a while, to make sure that he didn't have any further episodes of vomiting. I remember looking at the consultant and she looked back at me, and without needing to say anything, I got up and went to review him. So what was it that worried me? What's the big thing about button batteries? Well, in the past 18 months alone in the UK, 3 children have died having swallowed them. Many will pass through the body without causing any problems, but as this time-lapse video shows that was taken over an hour, if they get stuck against mucosal surfaces in either the gut, the ear, or the nose, they can start burning nearly immediately. The burns aren't caused by the battery leaking, but by the electrical current that they produce, which in turn produces caustic acid. Takahu's battery had been in place for 14 hours before it was removed, and I was still concerned that this was the cause of his problems. I went to go and review him and found him sleeping in his mum's arms. I was a little bit worried that his heart rate seemed a bit high considering he was asleep. The nurses then told me that his cannula had tissued and asked me to put a new one in, which I did, and again he didn't react as I would expect a 10-month-old to. Shortly after I'd done this, he collapsed in front of me and he was rushed through to the resus room where he was intubated and ventilated. Never before have I been so pleased to have a working line. As I pushed the blood in, his lips literally turned from grey to pink. We managed to stabilise him and he was taken to the operating theatre. While there, he had an endoscopy to try and find the site of the bleeding, and when this was unsuccessful, a laparotomy. Following this, he was taken to the intensive care unit and unfortunately continued to bleed and remain unstable. He was taken for a CT scan and this showed the root of all of his problems. As Takahu's esophagus had healed, he'd formed an aortoesophageal fistula and he was now bleeding into his stomach. He was taken back to the operating theatre and had a further operation to stop the bleeding. As you can see from this picture, Takahu survived, but most children who have this complication don't. He started school now, but he needs regular yearly dilations of esophagus to keep him healthy. But he's alive, and for that his parents are eternally thankful. So why did I jump up and go and see him immediately? Why did I leave the handover? Because I was worried about him. Well, I'm often asked by junior doctors why it is that when I go and see a patient they feel needs to come into hospital, I examine them and feel that they can be safely sent home. With time and experience, I've come to realise that it's not so much what I see, but what I don't see that matters. And I'd like to try and explain this using the analogy of a word search. You'll have to bear with me for this bit, it will make sense. My little boy Tom is 7, and every week he gets sent home from school with a word search to do for his homework. He finds these really tricky, and gets increasingly frustrated when I come across and seem to find the words immediately. So because of this, I've taught him a method, and it goes like this. The first thing that you have to do when you're doing a word search is to know the words on the list that you're looking for. In medicine, these are the symptoms and signs of severe illness that we're looking to rule in or rule out in our patients. Once you know the word list, you can go on to look at the grid. When we look at the grid, occasionally words will jump out at us immediately, like meningococcus does in this word grid. The reason for that is that if you were to go and see a child with a high temperature, lethargy and a non-blanching rash, I'd like to think that the first thing that would pop into your mind is meningococcal sepsis, because we're all trained to do that. However, once we've found these words that jump out, the rest of them are just a jumbled mess, and that's when we have to start looking systematically. I tell Tom to pick a word and to look for the first letter. Once he finds that first letter, he then needs to look at the surrounding letters and see if he can find the word. In medicine, this is when we do our investigations and when we do our examination. And in children, more than anybody else, it's the time when we observe them in the department to see what's going to happen. If you use this systematic approach, you will find the word that you're looking for. You may, in the process, find another word that's on the list, and occasionally you'll find words that you weren't even looking for. So what was it in Takahu that set off the alarm bells in my mind? Well, the combination of vomiting blood, the ingestion of the button battery 3 weeks previously, and his general clinical picture made me worried long before he collapsed in front of me. So let's see if we can use this system on another child. This is Scott, and Scott's 4. His mum's brought him to the emergency department today because she's worried about him. He's got a fever, diarrhea and vomiting, and he's developed a rash. And she just wants to know what's going on. What words are you going to look for to help you reassure her? What symptoms and signs do you need to find and exclude to be able to tell mum that this is just a viral illness? Well, personally for me, the first thing I'd want to know about is the colour of the vomit. Is it green, which might mean that he's obstructed, or is there blood in the vomit? I'd then want to ask about travel. Have they been overseas recently, or have they been to a farm? When I examine Scott's abdomen, I'm going to be looking to exclude any surgical causes. And you might have other things that you want to look for and exclude. But would you look at his skin? Would you find this burn on his thumb that happened a few days earlier on the cooker? This burn's so small that mum hasn't needed to go to the hospital or seek medical help. She has absolutely no idea that he's displaying all the signs of early toxic shock syndrome. Toxic shock syndrome is a rare but potentially fatal complication that occurs when burns or simple skin wounds get infected with staphylococcal or streptococcal organisms. In teenage girls, it can also be associated with tampon use, and most people know about this. The size of the wound is irrelevant, and the problem is that it's a very non-specific presentation. Children will have a high fever, diarrhea and vomiting, and a rash that looks a lot like a sunburn. Any parents that bring a child with a burn to the hospital or doctor need to be warned about the signs of toxic shock so they know what to look out for. Sadly, by the time it's thought about, children are often profoundly hypotensive and require intensive care support, and sadly some don't survive. If we don't have a methodical system of how to rule out serious pathologies in children, we're going to continue to see headlines like these in the newspaper. We need systems that allow us to pick up deteriorating children before it's too late. If you use the grid system with time and experience, you'll get much better at picking words out immediately. You no longer have to search so hard, and more things just jump straight out at you. Occasionally I see children and I find it difficult to explain exactly why I know what the diagnosis is. It's just a reflex. But equally, when I don't know what's going on, I think about it in a logical manner and I scan that grid looking for the things I need to exclude. So that explains the buttons and the burns in the title of this talk, but it doesn't explain the bombs. Well, to be honest, that's just to show that I'm not completely mad and I'm not the only person who thinks like this. If you speak to security staff in airports, they assume that every single suitcase contains a bomb until they can prove otherwise. They know that it's safer to rule out explosives than it is to rule in. If we take this same approach when we look at patients, systematically looking at causes of severe illness or injury, we're less likely to miss the ticking bomb of a deteriorating child in our waiting room, and we're more likely to have children like Takahu who go on to live a full life. Thank you very much.